Good morning. We have not hold classes for last few days because of ASICON. So we are having our regular academic session, and as I already intimated, from January we'll have the classes from 8 to 9 a.m. Today we have a operative surgery discussion on lateral pancreaticostomy with Freys procedure. So Dr. Shivajyoti Ghosh is professor of surgery at Calcutta Medical College. Will take us through the scenario. Dr. Nitesh was supposed to present, but one of his relatives is sick. So Dr. Milind Alokji will tell the scenario. So Dr. Ghosh, you can start with the usual approach.
Okay,
It's
so
a phrase.
someone has to present the case or the operative
Yes,
steps.
operative steps discussion. Operative
Right,
steps, post-op management.
right. So we all are very familiar with the cases of chronic pancreatitis, particularly chronic calcific pancreatitis. It is, I would say it's not so uncommon clinical cases we see in the OPD. At least 3-4 cases per week we see cases of chronic pancreatitis in our hospital. But in some areas like of West Bengal, like Murshidabad, or in some places of Assam or South India, it is a very common scenario, chronic pancreatitis. So now, who is presenting?
Sir,
Milind Alokji.
sir,
Milind.
good morning, sir.
Can you tell me the indications of operation in case of chronic pancreatitis, particularly chronic calcific pancreatitis?
Symptomatic chronic pancreatitis, sir. Symptomatic chronic pancreatitis is when the patient is having chronic debilitating pain, which is affecting the quality of life, associated with either a pancreatic duct obstruction or a duct dilatation more than 5 mm.
Right. So first and foremost is the indications for operation is pain, and you have to qualify pain, that is intractable pain, which is interfering with the daily activities of the patient, and more so if the patient cannot sleep at night. So that is number one indications. And other than this, other indications are when patients present with any of the obstructive symptoms due to chronic pancreatitis. So obstructive symptoms may be obstruction at the level of common bile duct, that is patient may have jaundice, or it may have duodenal obstruction, so patient may have gastric outlet obstruction, or it can be a portal vein, splenic vein obstruction can also be there. And also sometimes there may be a pseudocyst, associated pseudocyst. So these are the obstructive symptoms for which we may need intersurgical intervention in case of chronic pancreatitis. Other than this, there may be inflammatory head mass, right, in which you are not very sure about the nature of the head mass, right, when we cannot exclude malignancy in a inflammatory head mass in chronic pancreatitis. So that is another indications where we'll have to interfere. So in general, these are the indications of chronic pancreatitis. Now, before we intervene, so can you tell me some of the preoperative preparations for a patient when you will plan for, say, for lateral pancreatitis? Achha, before that, you tell me what are the various surgical options. You'll be talking on Freys procedures, but you'll have to also know what are the other options available for chronic pancreatitis. So can you just enumerate the various options?
Yes. One is
so we have restrictive procedures and we have obstructive procedures, sir.
No, drainage.
Drainage procedures.
One is resectional procedure and second is
drainage procedures.
Yeah.
Right. Okay. So just give me some examples of resectional procedures and drainage procedures.
So drainage is LP as a lateral pancreatico jejunostomy is a drainage procedure, sir, but I'm not sure about the other procedures.
Okay. So lateral drainage procedures is one is lateral pancreatico jejunostomy, LPJ, also known as Parrington-Rochel's procedures. Right, and Freys procedures also is considered to be one of the drainage procedures, although it is more of a hybrid procedures. And other than this, there is resectional procedures, right, where you resect the pancreas, pancreatic parenchyma. So these common resectional procedures are like Vegas procedures, with which is duodenal preserving pancreas resection, DHPPR, right? And also in certain cases where the only part of the pancreas is removed, but like if the chronic pancreatitis is confined to the tail of the pancreas, so we can do distal pancreatectomy. Or if it is confined to the body and body and neck of the pancreas, so we can do segmental resection, right? So these are the things. And when we are not very sure about the nature of the pancreatic head mass, then we'll have to go for formal pancreaticoduodenectomy, right? So that is another resectional procedures. So these are the various surgical options that you have, right? So accordingly, you'll have to choose the operation, right? So what are the indications of particularly lateral pancreaticostomy only? When you will choose lateral pancreaticostomy in a particular patient?
So we go for lateral pancreaticostomy when so the duct is dilated, so the pancreatic duct will be dilated, sir.
Very
And
good.
And so if there is
if you
stone or
have
debris is present,
stone debris,
Stone or
and
debris
if you have
present.
a ampullary stenosis.
Right. So when the main pancreatic duct is dilated without stenosis of the side branches, right? So that is indications for classical indication for lateral pancreaticostomy. Okay. But if there is inflammatory head mass, then the surgical procedures could be either Freys procedures or it could be Vegas procedures. Vegas procedures is not so popular, but Freys procedure is popular. So when there is inflammatory head mass, so we can go for either Freys or Vegas procedures. And when you are not very sure about the nature of the inflammatory head mass, whether to exclude malignancy, so we might have to go for Whipple's procedures or formal pancreaticostomy. Now, can you tell me some of the preoperative preparation that we need for when you plan for lateral pancreaticostomy?
We will have to, sir, basically fluid resuscitation, sir, and proper nutritional management of the patient, sir. So we have to ensure that the patient is properly hydrated and that his nutritional status is good to take the surgery, sir.
And some patients are diabetic.
Yes, and control of comorbidities, especially diabetes.
Because one of the presentation of chronic pancreatitis is diabetes. So you have to control the diabetes. And what do you specifically talk of nutritional aspect in this patient? What nutritional aspect is important in patient who is to undergo a anastomotic procedure?
So albumin levels have to be within the normal range. So hypoalbuminemia should not be there because it might lead to leakage of the anastomosis.
And what about anemia?
And anemia, sir. Hemoglobin should be adequate, sir.
Right. So these are the in general aspects for good recovery of the patient in a post-operative setting. But before that, just remember one thing, that some of the patients of chronic pancreatitis, they present in acute on chronic stage, right? So and patients have recurrent pain, and there is sometimes patient have acute exacerbation, right? So you'll have to decide at which point of time you will intervene. Because sometimes we see that we have opened the abdomen and we have seen that that pancreatic area is very much inflamed and there is a lot of vascularities. If you touch the pancreas, it bleeds. So in such a scenario, it's very difficult to go for this opening of the main pancreatic duct. So this situation can be assessed preoperatively if you do C-reactive protein estimations. Right. So when there is acute inflammation is ongoing, so if you do C-reactive protein, so that will be reflected in the increased level of C-reactive protein. So I think it's a good idea to check for C-reactive protein. If it is say more than 100 or so, so maybe we can delay the operations. We can just resuscitate or treat the patient conservatively for some times and let the inflammation and edema subside. Then we can intervene. So that is one important aspect other than checking the albumin and the hemoglobin and other things. Okay. Now, you tell me the surgical steps.
And one thing is, previously it was said that patient of chronic pancreatitis should earn the operation. That means patient should have internal pain and then, but recently there is some change in concept that you can offer early operation in some selected group of patients. Okay, patient who has got pain, patient has got ductal obstruction, gross ductal dilatation, containing multiple stones. So some situations, if you give the patient early operation, the quality of life and the outcome of surgery is better. So you should keep in mind that part also, that some patient may be offered early operations.
Right. So this goes by the classical escape trial, right? So in this trial, previously it was a concept that you delay the operation. So sometimes it used to say this there is burnt out of the disease. The patient will be pain-free after say 7 years, 10 years. But nowadays, this escape trial, which has have suggested that early surgical intervention may delay the onset of the exocrine and endocrine insufficiency, or those who are having endocrine insufficiency, like having high blood sugar, they may the requirement of either insulin or oral this thing anti diabetic agents. So requirement of those may be reduced if we go for early surgery. Okay, so that is one aspect. Okay. Now you tell me the steps. Can you tell me the steps of the operation?
First of all, so the anesthesia for the operation, patient will be under general anesthesia with endotracheal intubation. The position will be supine. After proper aseptic dressing and draping of the patient, we will start with first the skin incision. The skin incision, so we can go for a rooftop or a chevron incision, or and so then after the skin incision, the further layers will be opened along the same line. So the next step, once we reach the peritoneum and we open the peritoneum, the next step would be exposure of the pancreas. So the pancreas, for exposure of the pancreas, sir, we will first be dissecting the gastrocolic omentum, and on this section we will be able to expose the body and the tail of the pancreas. Then we go to the duodenocolic ligament, and we dissect that, and on dissecting that,
not resect. You bring it down.
We bring it down. We bring it down, and along with that, the right colic flexure, we bring it down, and that will expose the head of the pancreas. So, while doing this, we will have to also ligate the right gastroepiploic vein and some short branches of the gastroduodenal artery. Once having done this, then the next step would be cauterization of the duodenum. So for cauterization of the duodenum along the lateral part of the lateral margin of the second part of the duodenum, we incise in the posterior parietal peritoneum, and we cauterize, or we move the second part of the duodenum, and that will expose the head of the pancreas for us. We lift it above the inferior the IVC, and we expose the head of the pancreas. So after this, we further open up the gastrocolic ligament, and that will completely open the body and the tail of the pancreas, and then we'll have the pancreas exposed. So the next step would be to identifying the pancreatic duct. So in case the pancreatic duct is dilated or has multiple stones, it is easy to identify it. In case it is not, then we can use a 22 gauge needle, and lateral to the neck of the pancreas, at the junction of the upper 1/3 and lower 2/3, we put in the needle, and if we enter the duct, then the pancreatic juices will be there in our syringe. And so along the longitudinally along, then using a electrocautery, we can incise, while keeping the needle incise, we incise and open the duct. Further, we put in a metal dilator, and along as we extend the dilator towards the body and the tail, along it we open the duct towards the body and the tail, and then opposite side as well towards the head, we extend the dilator, and then we open it towards the head. So after doing this,
how far towards the head?
So we keep at least 1 centimeter away from the duodenum, sir.
Yeah.
We keep a gap of 1 centimeter. So once we have done this, then in case there is whatever stone or debris that is there, we use a Desjardins forceps and we take it out and we clear the main pancreatic ducts. After doing this, so then we come to the
you are supposed to do Freys procedure.
yes, sir.
So before you
yes, sir.
bring the jejunum, then
Yes,
you
sir.
have to do some
So
more procedure.
yes, sir. Freys
Why
procedure.
is a head coring required? What is the rationality of doing head coring along with the drainage?
Sir, because because of chronic pancreatitis, there is already a lot of chronic changes and the head mass is increased. So that so
It is said that the pacemaker of pain in pancreas in the head.
okay, sir.
So if you have the inflammatory mass in the pancreatic head, the pain component may persist. So it is observed that if you do a good amount of head coring, you remove the inflammatory tissue, the pain relief is much better than only doing a PJ. So that is why the Freys procedure is popular.
So,
Okay.
so then we have the Freys procedure head coring, sir. The mass that is there on the head, with an electrocautery, piecemeal by piecemeal, we take off the mass, leaving minimum 1 centimeter rim around the duodenum. So once we have done that, then we go for the pancreatico jejunostomy, 15 centimeters from the duodenojejunal junction. We divide the jejunum. We divide the jejunum, and the distal end is closed. This can be closed with the distal end is closed. So then this is brought from behind the transverse colon next to the the pancreatic duct, and a longitudinal jejunostomy is made. The jejunostomy is then anastomosed with the main pancreatic duct, which is done which can be done in 1 layer or 2 layers. If it is done in 1 layer, it is done in 1 layer, then through and through the suture is taken through all the layers of the jejunum and the pancreatic parenchyma, and the anastomosis is done. If it is done in 2 layers, then the inner layer is
In operative, describe one technique.
so
Then the examiner asks the next question, what is the other technique? The answer should be, I will use a 30 PDS suture for doing a single layer longitudinal pancreatic anastomosis. And once you open the jejunum, it is not jejunostomy, it is jejunotomy.
Okay, jejunum.
And if you have the pancreatic ductal opening, what should be the length of jejunal opening? Same or little less? It is little less.
Little less, sir. Little
because
less.
jejunal.
Remember, always when you are doing any anastomosis with the jejunum, say for gastrojejunostomy or say hepaticojejunostomy, right? So always incise the jejunum less than the other organs, like, because jejunum is highly stretchable, right? So if you just incise to the same length as like the stomach or CBD, so at the time of anastomosis, you'll find that jejunum is always jejunotomy is always enlarged or increased in size. So it is always said that it should be less than 1 centimeter from both sides. Okay. Then
yes, so once we have done the pancreatico jejunotomy, so then we have to for the maintaining the continuity of the intestine, then about 35 centimeters from the pancreatico jejunotomy, we again reset and we bring so we make the jejunostomy there, sir. And so then once we have done that, so then we close the mesocolon. We close the mesocolon and
so at any additional procedures you like to do? Like cholecystectomy, is it routinely recommended? Would you like to do cholecystectomy along with it?
So
okay, so some surgeons prefer to do cholecystectomy, right? Because there may be an obstruction in the common bile in future, and that may predispose to stasis or bile in the gallbladder and may predispose to gallstone. So some surgeons may prefer to do cholecystectomy. And feeding jejunostomy, depending upon how good, how confident you are with the surgery. So it also on surgeon's choice whether you go for additional feeding jejunostomy or not. Okay. Now, here are a few steps which you can remember that particularly sometimes in vascular pancreas. So it is a good idea to tie the gastroduodenal artery, like we tie the gastroduodenal artery in Whipple's procedures, right? So the blood supply to the head of the pancreas will be little reduced, right? That is one issue, we can do that. And secondly, it is always a good thing to start before you mobilizing the pancreas to just find out where is the superior mesenteric vein, right? Because that is the greatest fear. Sometimes during opening up of the pancreatic duct, you may go a little deeper and you can ensure the portal vein or superior mesenteric vein. So you'll have to have some ideas, just like we do in Whipple's procedures, where is the superior mesenteric vein, and you be careful that not to injure too much on that areas. And another technical issue is that particularly in this, when the pancreatic head is very vascular, we can put stitches, stitches along the head of the pancreas. You put on serial stitches on the head of the pancreas, just 1 centimeter, 0.5 centimeter from the duodenal end, series of stitches, and that can to some extent reduce the bleeding during opening up of the main pancreatic duct.
Yes, sir.
So these are few technical things that you can remember. Okay. So what are the likely postoperative complications in this patient?
So the first complication would be bleeding. Secondly, anastomotic leak, sir.
Right.
So then ileus, sir. Then
okay. So bleeding, yes, bleeding is one of the important complications. And anastomotic leak is relatively rare in chronic pancreatitis, because due to the chronic pancreatitis, the secretion is already reduced, and pancreas is also firm, right? So firm pancreas, reduced dilated duct, so chances of anastomotic leak is less compared to the operations like Whipple's operation also, where the duct may be not so dilated and the consistency of the pancreas is soft, right? So in this situation, chances of anastomotic leak is more. So, but bleeding, yes, there is a chances of bleeding in the postoperative period. So bleeding will be, bleeding may be extraluminal or maybe luminal, right? That means during mobilization, it can come from the retropancreatic areas, right? From that area it can be bleeding, but it can also be luminal bleeding. That means from the anastomotic side. So how do you know it is a luminal bleeding or it's a extraluminal bleeding?
so if there is bleeding present in the Ryle's tube, sir, then it will be intraluminal bleeding, sir.
Yes, very good. So luminal bleeding, you can see the blood in the Ryle's tube, and extraluminal bleeding, you see blood in the drain.
Drain, yes, sir.
Right. So accordingly, you have to decide what to do. Okay. Right. And what are the other, delayed complications of this?
Sir, recurrent pancreatitis, sir, or
Yes.
recurrent symptoms, sir.
Yeah, recurrence of pain.
Recurrence of
Right. So what is the, according to literature, what percentage of patient gets pain relief following surgical interventions?
Sir, around 75 to 80%.
Right. So that is very important, because you'll have to counsel the patient before the operation. Right. So how do you counsel the patient before operation? That is very important aspects of this operation, because not all the patients will going to get pain relief. Right.
That means, can you revert the disease process by doing this operation?
No, sir.
Drainage? No, that
No,
is
sir.
one. So you have to counsel the patient. Patient has come to you for pain, malabsorption, and diabetes. So what are the outcome of this operation, and how do you counsel the patient?
So, the episodes of pain might decrease, but we'll have to tell the patient that they still might continue.
So for proper counseling, you have to explain the patient what is the problems with this disease.
Yes.
The problem he has come to you with the pain, maybe he come with diabetes, maybe he have some malabsorption part. So you have to explain that the surgery you are considering is for basically pain relief.
Pain.
The other two may improve. Once with the drainage procedure, there may be some improvement of the exocrine function, but there is no guarantee that he may improve with the diabetes. That is one. Second is, you have to explain the patient that this is a major procedure. And this procedure has its own morbidity and mortality. Okay, although negligible, less than 1%, but still you have to explain all the pros and cons of the operation.
Right. So usually I counsel the patients like this. Okay, because most of the patients, they are the common man. They know about gallstone, they know about kidney stone, and now the patient is having pancreatic stone. So I tell them when there is gallstone, so the gallbladder has to be removed, and you get relieved, or your disease is cured. But in kidney disease, kidney stones, so only the stones are removed and kidney is left behind, and most of the time patient gets relief of his symptoms, and he may be cured if he follows certain lifestyle modification. But in chronic pancreatitis, it is a progressive disease of the gland itself, right? So if you remove the stone, the gland will, pancreas will not revert back to its normal function. So it is an ongoing process. So that they has to understand first. Secondly, about the pain, they'll have to tell that only 75 to 80% patient will get relief, 20% may not get relief, right? And thirdly is that it's not, sometimes there is parenchymal calcification. So all those things you cannot remove all those things. Only the ductal stones we can remove. So sometimes after operation, you have done the operation, and then in a follow-up period, patient has done another ultrasonography and he sees the stone in the parenchyma. Then we'll come again, doctor, what you have done, see the stone is still left behind. So you'll have to take all these things into consideration and tell them beforehand that these are the things. So you must understand that, and if you agree, then we'll go for surgery. Right. So these are the important things. Now for recurrence of pain, so 20% of the patient, 15% patient will have recurrence of pain. Now, so how will you manage those cases?
Sir, we will go for pain management through medications, or sir through neural blocks, sir.
Right.
Chronic pain management, sir.
So that is one option, right? We can go for ciliary plexus block. Okay, but ciliary plexus block, by and large, it works for 3 months, maximum 6 months. So after 3 months or 6 months, patient will again have a relapse of the pain, right? So what are we going to do then? What are the other options we have?
Sir, so we will go for then. So then, if we will go for resections, or then
can some endoscopy procedure help? Once you have a surgery being done, and then you have done a surgery with a PJ, maybe done your Freys plus minus. Any role for endoscopic treatment?
So stent.
You see, yes. Sometimes you have not interfering the sphincters. So patient having a pulmonary stenosis may have recurrence of pain. So some endoscopy in the form of sphincterotomy may sometimes help. Or if the patient has got a recurrence of stone in the pancreatic system, that can be cleared by endoscopy measures. So you have to always think of minimally invasive to again a surgical option, because surgical option again is a very major procedure. So drug treatment, neural block, and then endoscopy procedures.
Right.
Yes,
yes. So first, when the patient comes with a recurrence, so first you'll have to decide whether it is pain is due to pancreatic origin or it is an extra pancreatic origin. So there may be some other disease for which the patient is having abdominal pain. So you'll have to exclude that the patient is having some extra pancreatic pain. But if it is confined to or related to the chronic pancreatitis pain after the surgery, so first thing we'll go for ciliary plexus blocks. If it works fine, or otherwise, as Sir said, you can have endoscopic intervention option. But if it doesn't work or if the facility is not available, then we'll have to go one step ahead, as you said, or you said also. So if you have done say lateral pancreatic jejunostomy LPJ with headquartering and it's not working, patient is still having pain, so we'll have to go for head resection, right? Like biggest procedures. And if even after biggest procedures there is recurrence of pain, then we might have to go for total pancreatectomy, right? And remember that in all the cases of total pancreatectomy, it does not, have diabetes. There is some, due to some reasons or other, not necessarily total pancreatectomy means the patient will have lifelong diabetes, right? So some percentage of patient may not have diabetes even after total pancreatectomy. So these are all the theoretical aspects. Maybe at times we may need to do that. Okay. What else?
Some technical issues. You are trying to do a pancreatic jejunostomy, you cannot localize the duct. So is there any other ways to address this situation? You try to localize the duct, but you cannot localize the duct with puncture and others.
Sir, using high opaque dye, sir, we can do a ductogram, sir.
No, that means you have entered the duct, but you are not been able to enter the duct. So suppose you're walking in a very sophisticated hospital, so any gadgets can help you localize it.
Sir, ultrasounds,
Yes.
intraoperative ultrasounds.
Interval ultrasound, yes. That is another important way to get the duct. And if the duct is not very dilated, but patient has got severe pain and you decide to do surgery, what modification is there to do a drainage? ESBG procedure, where you can not have the small duct being seen, you can excise a core of parenchymal tissue and then do the anastomosis. Okay, this is ESBG procedure.
This is a small duct disease. So in chronic pancreatitis, either it can be very dilated, main pancreatic duct, or it may not be so much dilated, right? It's chronic, it's called small duct disease, like sclerosing pancreatitis, right? So all the side branches and these are all stenosed and fibrosed, and this produces small duct disease. So in this situation, we will have to remove a V-shaped tissue from the anterior surface of the pancreas. So when you do the V-shaped excision, so all the small ducts, so you make a crater. So all the ducts then open into that crater, right? And then you do anastomosis as you do in lateral pancreatic jejunostomy, right? And another technical issues, as I said, is that always remember that the duct feels soft. In chronic pancreatitis, the pancreatic parenchyma becomes firm to hard, right? So on the surface of the firm to hard pancreas, the areas where you feel soft, that is the areas of the main pancreatic duct. And always another thing you should remember, the position of main pancreatic duct, it is more or less in the middle of the superior pancreatic border and the inferior pancreatic border. So you'll have to define the superior pancreatic border at the beginning of the surgery, and also you'll have to define the inferior pancreatic border, right? So in between the superior and inferior pancreatic border, in the middle, you can feel the duct and soft things there, right? So that is how you will have to identify the main pancreatic duct during surgical procedures.
Dr. Acharji, any question? Pancreas is your favorite subject.
No, yeah, that's true. I think discussion is okay. Just one comment about the technique.
Yes.
That I have found easier for doing this anastomosis myself. That is, I usually do the anastomosis in so-called 1.5 layers. I fix the Roux-en-Y loop first with the non-absorbable sutures to the inferior part of the pancreas. so that it doesn't get loose, or some assistant does not have to keep it in position all the time. So I fix it with the
posterior cerebromuscular.
Yeah,
Posterior cerebromuscular.
I mean,
You mean a posterior cerebromuscular bite to
posterior cerebromuscular.
the
And then
pancreatic
I
pancreas.
usually do not open the jejunum to the full length that ultimately I'll be doing. I usually open a little, do the posterior there, then increase, go on increasing and putting sutures.
Yes, yes.
And whenever opening the incision, I find a bleeding point, I immediately take care of it, either with stitches or bipolars. Immediately. Don't keep it for management later on. Immediately. Otherwise, there will be blood. The field will be bloody. You can't have a good clean loop. So I go on doing that. That is just a personal choice. You may or may not use it, but I find for myself it a little easier when you fix it first and then go on increasing the opening of loop bit by bit. Doing the anastomosis all the time as you progress with the anastomosis.
Yeah, sometimes this happens that jejunal cut is more than you have to take more bite on the jejunal side, less on the ductal side. So it's difficult. It's better that you keep on making less and then continue till the end.
Go on doing this by bit, as with a small length, then small length, like that. And then usually we don't have any discrepancies later on in the length. Thank you.
Okay.
Thank you, Shivajyoti.
Thanks.
Vast experience with pancreas.
Yes. So, and I think one of the good gadgets for doing any surgery on pancreas, particularly lateral pancreaticostomy or headquartering, is a bipolar forceps. Because sometimes from when you incise the main pancreatic duct, particularly in the head region, and there is bleeding from the wall of the, the incision of the pancreatic head, and that is very difficult to control. So if you have bipolar, and that is very easily controlled, and if it doesn't control with the bipolar, then you might have to use 30 or 40 Prolene material to ligate those vessels. But on average, bipolar is very useful. Another useful gadget is ligature. And if you have the ligature, then your life will be easy. I think Professor Saha is using some kind of instrument.
Bipolar sealer.
Which is like, chotoder ligature. It's very
good.
Comparatively, but useful. I have that hand instrument, but I don't have the generator. So
generator is very cheap. You see, Chennai made.
Professor Saha. Professor Saha.
I've used that and I found it very useful.
Professor Saha. Just a comment. I have been using these vessel sealers for quite some time. Actually, I have a generator in my possession. What I have found is that the locally made generators do make a little more significant lateral thermal damage than the original, instrument produced by the parent company. The original company.
It may be that, but it did not face a lot of major problems with that.
No, I have faced a little problem while doing. Nowadays I do almost all the hemorrhoids with vessel sealers. So what happens? Initially when I first started doing this vessel sealer hemorrhoidectomy, there has been lateral damage to the skin, and the patient used to have a lot of burning later on during postoperative period.
But then instrument should be fine. You see, if there is a larger blade instrument, that is more damaging.
I have that, and nowadays I use that only while sealing the pedicle, not during initial dissection. So a little away from the skin. Anyway.
Okay, Dr. Ghosh, I think we have gone through the whole part. The idea is to just for a exam scenario.
Yes.
Okay, that way is fine.
So, these are the described nicely. I think for examination purpose, he has done pretty well.
Thank you, sir.
And so read also something about the causes of pain in chronic pancreatitis, because that is a pet questions for the examiners. and also various surgical options, I mean classifications, this drainage procedures and then dissectional procedures, then hybrid procedures, right? Then the steps you are describing nicely, and also some post-operative complications and manage of the post-op complications, and also you'll have to remember the recurrence of pain and how to manage the recurrence of pain. So these are the standard questions. I think you have answered very nicely. Thank you very much.